I'm Kui Yong. I'm a hematology consultant at University College London, and I'm here to tell you about the results of our study called Cardamom. Cardamom is a clinical trial for patients with newly diagnosed multiple myeloma who are eligible for upfront stem cell transplantation. And in Cardamom, we asked the question, can patients who've made a good response to an induction regimen be delayed their stem cell transplant without coming to harm? So the induction regimen we used was carfilzomib, cyclophosphamide, and dexamethasone. We call this KCD. And for patients responding well to KCD, patients received a stem cell harvest and were then randomized to receive 4 more cycles of KCD or stem cell transplant. What we aimed to show was that the progression-free survival of patients who didn't have a transplant but continued with KCD chemotherapy was non-inferior to patients who had a transplant. And this non-inferiority was set at 10% reduction in progression-free survival at 2 years. So I will take you through the study results. The background to the study is that we've actually had 2 big phase 3 studies addressing the question of stem cell transplantation for newly diagnosed myeloma patients. But those studies used lenalidomide maintenance, and neither of them used carfilzomib as an induction regimen. We used carfilzomib because it's a second-generation potent and active proteasome inhibitor, and we also used carfilzomib maintenance instead of lenalidomide maintenance. This is the design of our Cardamom study. I've talked already about the KCD induction and then the randomization here to receive a transplant of 4 further cycles of KCD consolidation, and all patients received carfilzomib maintenance. Note that in the study, we looked at MRD response after stem cell harvest and before transplant. We also looked again at the MRD response after transplant or chemotherapy, and again at 6 months of maintenance. And these results that I present to you today are really focused on the primary endpoint of progression-free survival at 2 years. Here you will see that the patient cohort, we recruited and registered 281 patients. And here you see the breakdown in terms of the ISS and the RISS stage. I would point out that nearly half of the patients were over the age of 60, and around 18% of patients had high-risk disease. Amongst patients who are randomized to a transplant or a consolidation, these characteristics were balanced across the two groups. And at time of randomization, the disease responses were also balanced, with about 10% of patients achieving CR or stringent CR, 2/3 of them achieved at least a VGPR, and around 27 or 28% were MRD negative. This is again the flow through the study showing you the numbers of patients. 278 started induction and 228 had a stem cell harvest, of whom 109 were randomized to a transplant and 109 to consolidation. Here you see the details of why some patients did not proceed but from induction to a stem cell harvest. Some people didn't proceed because they had disease progression. Others didn't proceed because of toxicity and they stopped treatment, and other patients because of an inadequate response. So let's come to looking at the disease responses. And on the bar chart here on the right-hand side, you will see that the response to induction therapy was high. It was nearly 90%, and 58.5% of patients achieved a very good partial response. This increased to 77% after KCD consolidation, and increased further with ASCT. In red, you see the MRD negative response, which is 24% after induction, increasing to 35% with consolidation, but 53% with transplant. So you will see here that the MRD negative response is in fact significantly higher after the transplant. And here you see the significance value, a p-value of 0.02. We've also looked at the responses in broken down into patients with standard risk or high-risk disease with genetic risk defined traditionally. Once again, you see the high overall response rate, generally also the high VGPR rates, increasing with either consolidation or stem cell transplant. This is in the standard risk group, but in the high risk group, we see more or less the same, with an increase in response rates after consolidation or ASCT. The increase in MRD rate is also seen from an induction MRD negative level of 25% to 37%, with consolidation of 48% with ASCT in standard risk patients. And in high risk patients, the MRD negative rate after consolidation is 31%, but it is 66% after ASCT. This looks to be much higher, but this is actually a very small group of patients, of 19 patients. So there is some uncertainty around this figure. Here is the progression-free survival. So this is the primary endpoint of the study. And you will see here that the 2-year progression-free survival for patients receiving ASCT was 76%, compared to 70% for patients receiving consolidation. And according to the statistical powering, this is not non-inferior for KCD consolidation. And what this means is that if the outcome in terms of the 2-year progression-free survival for patients receiving consolidation instead of a transplant is not non-inferior to ASCT. However, the difference is small. The median follow-up, I will point out, is 37.5 months. So this is relatively short. Perhaps with longer follow-up, the difference between ASCT and consolidation will increase. We looked at different subgroups of patients, and you will see here a forest plot. So the hazard ratio, which we use to estimate the non-inferiority of consolidation, the hazard ratio is 1.28. And broadly speaking, if you look at subgroups in terms of age, sex, ISS and RISS stage, genetics, and response to induction, the hazard ratios are broadly speaking more or less similar to the hazard ratio for the group as a whole, and none of this is significant in terms of the subgroups. So let's look at the genetic risk. We looked at patients with high risk versus standard risk, and on the left-hand side, you will see that patients with high-risk disease had a lower progression-free survival of 1.7 years compared to 5.7 years median for the standard risk patients. On the right-hand side, we've tried to look at whether standard risk or high-risk patients had different outcomes depending on ASCT or consolidation. And you will see here for standard risk patients who are represented in the solid lines, with green for ASCT and red for chemotherapy consolidation. You can see that for standard risk patients, these curves are really very close together with little difference between them. For high-risk patients, the patients who received a stem cell transplant looked like they did better initially, but there is no significant difference in the curves. I will draw your attention to the fact that there is a mistake down here in the figures, and that the median PFS of 4.7 years in fact refers to the standard risk patients who received consolidation, and that the high-risk patients who received ASCT had a median PFS of 2.1 years compared to 1.2 years for consolidation. The MRD data are illustrated here. So we would expect patients who are MRD negative to have a longer PFS than patients who are MRD positive. This is what all previous studies have shown us. And indeed, in this study, the same answer is seen. Here you can see that patients who are MRD negative have a longer PFS than patients who are MRD positive. The p-value is 0.07, but I feel that with longer follow-up, this will be significant. The real question is whether patients who are MRD negative before transplant can get away without having a transplant, and what their PFS on consolidation looks like. So here is the answer. If you are MRD negative post-harvest, that is before randomization, the outcomes for the ASCT in green and the consolidation in red are really quite similar, with a hazard ratio of 0.8 and a p-value of 0.7. Whereas for patients who are MRD positive at harvest, you'll see that the difference in restricted mean survival time is minus 0.4 years for consolidation compared to transplant, and the p-value is significant here. So this is, I think, one of the most important findings of our study, which is that the benefit of stem cell transplantation may be seen more clearly for patients who are MRD positive after induction compared to those who are MRD negative post-induction. And here are the conclusions and summary and conclusions of our study. The carfilzomib dose of 56 milligram per meter squared with cyclophosphamide and dexamethasone produces deep responses, and we see a 24.3% MRD negative rate. The VGPR rate increases and is similar between ASCT and consolidation, but the MRD negative rate is higher post-ASCT compared to consolidation. This hints at the fact that the PFS will be longer with ASCT, but for our current follow-up, the 2-year PFS is longer. It is not non-inferior, but the margin is small. We've looked at high risk versus standard risk patients, and we can see that their PFS is inferior. But if we look at the different genetic groups of patients, in neither group is there evidence that ASCT is more effective than KCD consolidation. And I've already emphasized our findings about MRD positive patients at randomization who may derive more benefit from ASCT than from consolidation. And I acknowledge my co-investigators, all the team at the Clinical Trial Center, the LEADS team who carried out the MRD analysis, the trial steering and data monitoring and ethics committees, all the recruiting centers, and of course, all Cardamom participants and their families and our funders.